It needs some change.
Neighbor to neighbor?
That's okay.
Oh, no change.
Keep the change.
But, I'm sorry, help us with neighbor to neighbor. We had the drill the other night. I hope everybody at least enjoyed it to a point where they felt they learned one thing, two things, three things. And we're also under criticism because of things that maybe could be done a little better, a little sharper, a little neater. Yes, we understand that. We wanted to keep it kind of chaotic so that you'd understand that that's the way it could be. Of course, we learned from it, and from that, and that book that you all brought, Bill is the one who wrote that book. And
Samaritan, nice job, Bill.
good job.
Thank you.
And he was gracious enough to let us have it and copy it and get it to everybody that would be interested in doing what we're doing. So without any further ado, I'm going to turn this over to Bill so that we can get started. And again, questions, I guess, will be answered whenever, or
If you got them, throw them at me. We'll see what we can do with them.
The
So,
winning lottery numbers?
since this is going to be a recording, I'm going to be on the microphone, but I'm not really used to using a microphone, as you can tell. So this might be a little bit unusual, but I'll try to use it as best I can. I know I've seen a lot of you before because I recognize some faces, and I really appreciate your coming out for this. This, like the chief said at the drill the other night, this is something that puts you guys head and shoulders above every other community around here. Let me tell you, you guys are doing a fantastic job for your community, and you ought to really take a lot of credit for that. And especially Carl, I know he just knocked himself out putting this thing together, so it's well worth it. You never know when this stuff is going to be needed, and hopefully, you never will. But if you ever face a situation that you've never dealt with before, it's always good to have some sort of experience with it, so you have some idea what to do. Anyway, this is my business here. I had to pick a business name in order to become certified for my instructor credentials back several years ago. And so this is actually my business name, Life Support Training Services. And with that, we try to communicate to anybody that's wanting to hear it. Church groups, retirement communities, doesn't matter. Anybody that wants to learn what to do in case of an emergency, I'm here to try to help as best I can with that. And so some of you may or may not have been in some of my classes, so let's see if I can make this work. Well, it went. There it goes. Go back one. I'll get it. There we go. Okay, so the title of this, and it's kind of neat to have a little background on how this came about. Years ago, about 20 years ago now, when I was a paramedic, I had a church group that actually contacted me and said, we have a bunch of Sunday school kids here, and you guys get here pretty quick with the ambulance, but is there anything that we can be doing in order to help these kids until the ambulance gets here? And as a result, Good Samaritan's Guide to First Aid. What can you do, until the ambulance gets there? Now, this is not an attempt to make anybody certified in first aid or first responder or EMT or anything like that, but it's to make you somewhat comfortable in case you are faced with a situation that you've never seen before. And so this book has been used, and it is being used in several different organizations right now. And I was honored when Carl asked if he could use it here. I think that's wonderful. If you guys get some value out of it, that's tremendous. And so what I want to do is take you through this and maybe give you some reasons why we did some of the things that we did. But if we turn first of all to the table of contents, you'll notice that it's alphabetized. all right? My weird brain says, let's try to make this as easy as possible, because in the heat of battle, when you've got an emergency and you're trying to locate some information that you might need, let's make it as simple as possible to do that. And so everything is arranged alphabetically, and then secondly, these are the typical types of things that you may encounter in a typical situation around your community, or in this case it was in a church. But these are by all means, this is not every emergency that you could ever encounter, but these are the types of things that you are most apt to encounter. And so, just reading down through the list: allergic reactions, which could be as a result of a lot of different things, bleeding, bone, joint, and soft tissue injuries, breathing emergencies, burns, choking, head, neck, and back injuries, heat emergencies, nosebleeds, seizures and convulsions, shock, and by that we're not talking about electrical shock, we're talking about physical shock, a bodily shock. There's actually 8 different forms of shock, and so we as first responders, we treat them all the same way, but the idea is, how do you recognize it? What do you look for to find out, if someone is actually experiencing shock or going into shock? And then stroke, which some of you may have heard of. A lot of different information has been put out over the years on TV and various publications about stroke and how you can recognize it. And so we're going to talk about that. And finally, a patient that may be unconscious or unresponsive. And so, that being said, let's start with page 1. Actually, it's page 3, but it's the first topic, and that is allergic reactions. First of all, with an allergic reaction, it can be life-threatening, all right? It is something that, depending on how allergic someone might be to an allergen, it could actually become a life-threatening situation. We picked up a girl at a church picnic one day after they had a dish-to-pass dinner after church, and she was experiencing anaphylactic shock, which is an allergic reaction. And trying to find out what was causing it, of all things, it was celery. Okay? She had eaten from a dish to pass, and she became allergic to the celery, a violent reaction. And as a matter of fact, she went out on the way to the hospital despite different medications and everything else, and then we got her back on the way, but we actually ended up going to her house later that night for a second reaction after the drugs that they gave her at the ER wore off. And so we don't know what's going to trigger, and many times the patient doesn't understand what's going to trigger a reaction because we don't know. And so if it's an allergic reaction, not knowing the severity of it, the best thing to do is contact 911, get them on the way right away. And then that way they can check them out appropriately, get them to the hospital if necessary. But it's not anything you want to mess with. It's something that you want to react quickly, because depending on how violent this allergic reaction may be, they may only have minutes, and so you've got to really act quickly on this. If it happens to be a bee or a wasp or some such thing that has stung them and caused this reaction, one of the things that you want to try to do is get the stinger out as fast as possible, because like if it's a bee, that stinger is removed from the bee, it stays in the wound, but it keeps pumping. And so you want to remove that as quickly as possible, and we found the easiest way to do that is just scrape it with a credit card. It pulls the stinger right out. Also, there are many people that they have a knowledge of their reaction. They know that they're allergic, and so they have been prescribed an Epipen, which is epinephrine. Epinephrine is adrenaline, folks. It's the same thing as adrenaline. We all have it in our system, and so some people, to offset this allergic reaction, they need a super dose of adrenaline, if you will. So they need an Epipen. And those people that are severely allergic usually carry an Epipen with them, or it's nearby. And so If they have an EpiPen, remind them of it. Do you have it with you? If so, encourage them to use it. Don't use it for them, let them use it on themselves. We had a gentleman at our pickleball courts that was stung by a bee one night, and he freaked out. Oh, I'm allergic. And I said, Tom, do you have an EpiPen? And he says, yes, I do. And I said, well, then why don't you get it out and use it? And as he's uncapping it, of course, he's shaking like crazy because he's afraid. He truly is afraid. And so I said, have you done this before? Well, no, but I know how to use it. And I go, okay. So he took this EpiPen and he jabbed it in his thigh and he just went, and he took it right back out again. It probably wasn't in there for 1 or 2 seconds. Well, folks, it needs to stay in about 10 seconds to release all that medicine. And so I said, Tom, do you have another one? He says, yeah, as a matter of fact, I do, but it's at my house. So I went with him to his house, and then I administered the second one to make sure it was done the proper way, because he was very nervous, he was very scared. So understand what that's all about and just assist the patient as best you can. Try to keep them calm, okay? Because help is on the way. We've already called 911 in step 1. They're coming, so all we have to do is just monitor this patient for a few seconds, for a few minutes actually. It may get to the point where the airways have tightened so much that they actually stop breathing. And at that point, what's your course of action? CPR. That's all we can do. All right, so just monitor them, make sure that they're breathing properly, and if they're not, and they need some assistance, let's get ready to do the CPR. Now, we're not going to teach you CPR tonight or even on Thursday night, because the assumption is that you've been through a CPR course, either what I taught or someone else somewhere along the way. And if it's necessary, we'll come back and we'll do a CPR course by itself. Any questions on allergic reactions before we move on? All right, next one is bleeding, and many of you, or at least some of you, were in my Stop the Bleed program here back a few months ago. And so we're not going to spend a lot of time on how to do this, but again, if you have life-threatening bleeding, we're not talking about a minor scratch. Everybody knows how to deal with that. Okay, we don't need to call 911 for something like that. What we're talking about is a life-threatening situation where the bleeding is severe. And if that's the case, again, time is really of the essence, and so we've got to get the professionals on the way as fast as possible. Step 1, call 911. Get them here as quickly as you can. Next thing is put direct pressure on the wound using gauze or a clean cloth. If that's not available, use a dirty cloth. Use whatever's available. It doesn't matter. The thing that you have to remember is the only thing that stops bleeding is pressure. So you've got to put pressure, pressure, pressure. Yes, ma'am?
What if you have glass on the wound and you can see it?
If you can see it, you don't want to put pressure on that, obviously.
Yeah, obviously.
Now, if it's something that is easy to remove without causing any further damage, normally you want to leave a penetrating object in the wound because that helps clot the wound. But if it's going to interfere with treating the wound, then carefully remove it. But again, I say carefully because you don't want to be cut yourself. Normally what you would do if you have an impaled object, you want to leave it in place and you want to pack around it and put pressure around it. All right, does that make sense? Okay.
I was thinking, in case of an activation, if we had a problem here, there'd be people out wandering, checking their property, they'd have flip-flops on or something like that. And,
Yeah.
And there could be glass, there could be stepping on.
Sure.
What do we do? Leave it there? Leave it in there? Or?
In most cases, we're going to. Most impaled objects, you're going to. All right.
It's very deep, yeah, I guess
Yep.
if it was shallow, you might.
The only time that you remove an impaled object is if it's in the cheek. All right, everything else you leave it alone and pack around it, put pressure on it around it, stabilize it so it doesn't work back and forth and worsen the wound. If it's in the cheek, you want to remove it because that can interfere with the airway. So you want to remove it from the cheek. And if you think about it, if you're trying to control the bleeding in the cheek, it's pretty simple if you get the object out of there because now you can put pressure on both sides of it. So that's fairly simple. But the chief reason why you remove it from the cheek is because of the airway. You don't want to compromise the airway. Thank you for the question. Any others?
I was just wondering, is that gonna, are you keeping up with it up there? Or?
No, I'm flipping pages. Okay. All right, so the next part is, after we put some direct pressure on the wound using gauze or a clean cloth, if it's not controlled, if that pressure isn't sufficient, and then we have to take it a little bit further. If it's uncontrolled or if the blood is spurting, what's that telling you? If it's spurting, it's an artery, isn't it? Every time the heart pumps, right? That's a pretty serious wound. And so if it's spurting or if it's pooling or if it's soaking the clothes, you want to apply a tourniquet 2 to 3 inches above the wound, or you want to pack the wound. And you want to apply forceful pressure. Pressure is the only thing that stops bleeding. It's either pressure from direct pressure with your hands, or it's pressure from a tourniquet, or it's pressure from packing the wound with packing material and then pushing on the packing material. But that's what stops bleeding. You have to apply pressure. Do not loosen the tourniquet. Once you apply it, the only people that take the tourniquets off are paramedics or doctors, all right? The only reason why we used to loosen them, years ago, we used to teach like every 15 minutes, loosen up a little bit and see if the bleeding stopped. No, 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 no. American College of Surgeons has now come out and said, no, put it on, leave it on. They have found with their studies from Afghanistan and Iraq wars that these tourniquets can be applied and left on for several hours without detrimental effects. We used to believe that once we tied a tourniquet on, that limb was going to have to be amputated. That's not the case anymore. But what is critical, and it's also in your instructions, record the time that you applied the tourniquet. The doctor has to know how long has that circulation been shut off in that limb, because if he knows how long it's been, he can calculate how quickly to release the pressure on that tourniquet. If it's been on there for a short period of time, then he can release the tourniquet fairly quickly. But if it's been a long time, then he has to remove it slowly so that it doesn't release all the toxins and get into the system. So any other questions on bleeding?
Question.
Yep.
I just, for my clarification, when you put a tourniquet on, you're gonna put it closest to the heart, at the area closest to the
Yeah,
heart.
it says 2 to 3 inches above, and when we talk about the term above, it's between the wound and the heart.
I
So
was
it's,
just clarifying.
yep, so it's always between the wound and the heart, so it's closer to the heart. Thank you for bringing that up. But that's exactly what we mean by above the wound, all right? All right. Now we move on to bone, joint, and soft tissue injuries. We want to minimize movement for joints and bones and manually stabilize. Now, what do we mean by manually stabilize? We want to hold it so it's not moving freely. So we want to grab a hold of that bone or that arm or that joint, whatever it is. We want to hold on to it to keep it from moving around freely, because we don't know whether it's fractured. Unless you have x-ray vision, you're not going to know, all right? So you don't know if it's a sprain, a strain, a fracture. You don't know what it is. So the important thing is that we keep this thing immobile as much as possible. We stabilize it, because if it is a fracture, we don't want the bone ends rubbing and creating more damage, and in particular, destroying blood vessels, all right? So we want to manually stabilize that bone or joint injury. If it's a soft tissue, that's something different, but bone and joint injuries, we want to minimize the movement. So we want to manually stabilize, and that in most cases, all that is just grabbing hold of that limb and just holding it in position to keep it from moving around. That's really all it is. If it happens to be a joint or a bone injury, then you want to call 911, all right? Because it's going to need to be x-rayed. They're going to have to go to the hospital. So let's call 911. In many cases, they're probably going to put a sling, maybe some splints. It depends on what the situation is. If it happens to be a femur, they're gonna have to use a special splint. And so you want 911 coming if it's a bone or a joint injury. If it's soft tissue, that's a different story. Okay, if it's soft tissue injury and it doesn't involve a joint specifically or a bone, then 911 may not have to be called. It depends on the severity of that soft tissue injury. If somebody just got whacked really hard, didn't open up the skin, and you know it's going to be a severe bruise, well, there's not a whole lot anybody can do about that. However, no matter whether it's a joint, a bone, or soft tissue injury, one of the things that you as a first responder can do is you can ice it. You can put something cold on there in order to minimize the swelling, and it helps with the pain to some degree. And so you can use an ice pack, or in some cases you might just grab some ice and throw it in a towel and put that on the wound itself. And so never, ever, ever apply ice directly to the skin. You can do some damage that way. Always have something between the ice and the skin itself. Terry cloth, shirt, t-shirt, whatever's available, but put something between the ice and the skin. Any questions on that one? All right, breathing emergencies. If it's a breathing emergency, you need the professionals here as fast as possible, because they're going to be able to administer oxygen. They may have to do an intubation, but you want those fellas here, or those people here, it could be some ladies too. You want them here as quickly as possible. So first thing should be call 911. If they come and check the patient out, find out it's not a big deal and they're recovering, okay, they can go back home again. It doesn't matter, but make sure that they're here as fast as you can get them here. Do not make the patient lie down. It's actually harder to breathe when you're laying down. And so put them in a position of comfort. If they feel more comfortable sitting up, which they probably will, let them sit up. In many cases, what will happen is they will not only be excuse me, sitting up, but they'll be leaning forward and they'll probably have their hands on their knees. It's actually called a tripod position. What they're trying to do is they're stretching out the diaphragm so it makes it easier to breathe. They need that diaphragmatic muscle moving up and down to make it easier to breathe. And so many times they'll lean forward on their knees like this. So let them do that. Don't force them to lay down, because that makes it more difficult to breathe. Loosen the clothing at the neck and the waist. Again, for obvious reasons. Anything that's restricting their breathing effort is just going to defeat the purpose. You're trying to make it easier for them to breathe. And so loosen the clothing at the neck and the waist. Again, the waist because of the diaphragm, and of course the neck because it's easier to breathe and get the air through. If breathing stops, our only alternative is CPR. Right? We've got to go to CPR. Okay? Any questions on this one? Burns. Burns. If the skin is blistered or charred, call 911. That's a pretty serious burn, right? If we've just got a lot of redness, like a sunburn, real bad sunburn, or a scald, or something like that, do not break those blisters. That's acting as a protective. It's keeping the infection out. Once you open those up, now you're allowing all the outside stuff to get in there, and you could infect that wound, that burn. So if the skin is blistered or charred, call 911 and don't break the blisters. Next thing we want to do, and actually the first thing we want to do after calling 911, is we want to apply cool water. The first thing that we have to do for this burn is we have to stop the burning process. Think about this. If you put a piece of meat, let's say on the grill, you cook a steak on the grill and you take it off and put it on the plate, is it still cooking?
Yeah.
Absolutely it is. And so the same thing happens if we get a burn on our skin. Until we take away that burning process, that's still burning. That skin is still being burned. And so the way that we offset that is by using cool water. Notice I didn't say cold. It's cool water that we want to put them under. And we want to do it for 20 minutes. And this will stop the burning process, and it also helps with a little bit of pain relief. We had one guy that was cooking spaghetti on the stove one day, and he had shorts on, and he knocked this pot of boiling water onto his legs. And the first thing that we did is we stripped him down and put him right in the shower, right at his house. Before we even tried to load him in the ambulance, we just stripped his shorts right off him. We run him right into the shower, and we put him under some cool water in the shower. He was shivering by the time he got out, but he was thankful. So get him under some cool water and get that burning process stopped as fast as possible. You can use a cool wet cloth if you're unable to place them under running water. So the best thing to do is just, if you can, like if they burn their arm or so, hold it under a faucet. Let that running water just run right over it constantly, and keep them there for 15 or 20 minutes. If that's not possible, then the next best thing is get some cloths, soak them down, put it on the wound, and keep pouring water on that. See if you can cool it off that way. We want to re-wet those cloths every few minutes. We want to keep it cooled down. So that's the process with burns. Any other questions? Okay, pretty straightforward stuff. Choking. If they're choking, call 911. All right, it might be over with in a matter of a few seconds, but you still want to call 911, because many times when someone is choking, they may have caused some sort of internal damage. And it's best that they go through an x-ray process to find out if there's any injuries that have been as a result of that choking. And so, first thing to do is call 911. If they are able to, this is the victim now, if they're able to, you want to encourage the victim to cough. So if you hear a bunch of noises, they're moving air. Okay, that's a sign that they're getting some air movement. So they've got something happening. And so at that point, what you want to do is encourage them to try to cough that, whatever it is that's blocking them, you want to encourage them to cough that up. If there's no noise whatsoever, they've got a total blockage. If you don't hear any noises whatsoever, they're totally blocked. And at this point, the only thing that you're going to be able to do is abdominal thrust. What most people are familiar with is the old Heimlich Maneuver. Dr. Heimlich invented that many years ago. So if you know how to perform that, then that's the time to do that if they're totally blocked up. Do not hit them on the back unless you're in Australia. True story. I was in Australia in 2018. My wife ended up going to the hospital by ambulance. When we were waiting for her to be tested, I was talking with the paramedics that took her in, and I had heard, and I didn't know for sure, but I had heard that they actually take an adult patient and they will hit them on the back when they're choking. And I thought, wait a minute. I said, if you do that, what happens to the object? Well, it actually goes down further and gets stuck. I said, so why do you do that? And he says, well, we don't hit them while they're standing up. We ask them to bend over at the waist. And then we hit them on the back. So if it loosens up, hopefully then they'll spit it out. I said, you're the only country in the world that I know that does it this way. Why do you do that? And he says, well, we're from down under. True story. That is a true story. That actually happened. But we do not want to hit them on the back. Yes, ma'am.
I have a question. In the CPR first aid or Red Cross folder that we had received, it tells you for CPR, just hit the patient on the back, 3 strokes to the back.
For choking? That's true if it's an infant that you can turn upside down.
It doesn't say anything about an infant. That's I just.
Yeah, it's.
And I think it's an old.
Yeah, it's not true with an adult patient. The only time that we hit the patient on the back is if they're small enough that we can tip them upside down and get their head lower than their body. And then when we hit them on the back, that object, if we loosen it up, it's gonna, by gravity, it's gonna come out their mouth and come out. But if we have them upright and we hit them on the back and we loosen it, it just goes deeper.
That makes sense. I was
Yeah.
surprised to see this, because I was reviewing stuff before
Yeah.
before we had our, thing, and I saw it, and then it's a conflict. There's another conflict when we get to it.
Okay.
Okay, and then,
Let's see. Never blindly put your fingers into a child's mouth. Why? Well, you might bite it, yeah. What's the other reason why we don't do
Push
that?
it further down.
You might push it in further, okay? So never blindly put your fingers in the mouth to try to see if there's something in there. If you open up the patient's mouth and you do see an object, then you can reach in and get a hold of it. But never blindly fish around in there and see if you can find something, because you may just make it worse. And if the patient becomes unconscious, then we turn to page 19, okay? Because remember, we had the last topic in our table of contents was unconscious or unresponsive. And so if we turn to page 19, that'll walk us through that process. And we'll get there when we get there, all right? So, any other questions about choking? All right. Let's move on to head, neck, and back injuries. If there is any, and I capitalize that, any possibility, if you have any suspicion or even thought that it's possible that there could be a spinal injury of the neck or the back, then you need to call 911. Yes? Thank you very much. I should give this to you, Brian, let you do it.
There you go.
Oops, sorry. Okay. That's, yeah, because it just broke.
Battery popped up.
Yes.
clarify that.
You didn't play basketball, did you play? You swam.
Conscious choking adult cannot read, speak, or
Blind
check
drug.
scene, check person, have someone call 911, obtain consent, lean the person forward. Okay,
It says,
and that's,
all right.
and that's what they were telling me in Australia. They said they have the patient bend over at the waist and lean forward, and that's what this is saying.
It doesn't look like he's that
Yeah,
far over.
no, it
so
doesn't,
it's
it
like,
doesn't.
you know.
But that's what it
That
says,
means the right hand?
lean the patient forward,
Right direction.
so. I still wouldn't do it like that.
No, okay, no, I just,
Try this.
Yeah, but
it's a Red Cross one.
I appreciate you bringing that up, but that is the new, that's the protocol over in Australia.
Well, let me try reversing the batteries. Well, okay, I will. No, let me try reversing the battery.
And then the one that advances it
That's
is the
it.
bottom one.
Okay. I'll get her.
Okay,
I'm confident.
I am
Here we
too,
go.
otherwise I wouldn't let you
Drum
have it.
roll. There
You
it
gotta
is.
point it there.
Okay, we're good.
Okay,
Head, neck.
head, neck, and
Head,
back
neck.
injuries. There you go. So again, to emphasize, if you have any thoughts that there's a possibility that there could be a neck or a back injury, call 911. Because they're now gonna have to put a neck collar on them, they're gonna have to put them on a backboard, they're gonna have to immobilize them. If there is a potential spinal injury, you must manually stabilize the head and neck by holding the head in position. Obviously, the way that you do this is the patient has to be laying down somewhere. All right, and then what you're going to do is get at the head of the patient, and you're actually going to hold on to their head right around their ears with both hands to keep them from turning their head or nodding up and down, because they'll do that. You ask, and that's the bad thing. When you start asking them questions, well, no, I don't think so. That's not a good thing, all right? So that's why you have to have manual stabilization of the head and the neck. Here's an example I gave a lot of my students in some of my classes. Take a nickel and put it over top of a quarter. Look at the distance between the edge of the nickel and the quarter, which is really tiny. I mean, you can imagine. That's the distance that it takes before someone can be paralyzed.
Holy cow.
Okay? So it's nothing to mess with. And that's why if you have any suspicions at all of having a potential for a spinal injury, then you need to take the appropriate precautions. The quarter is about the size of the spinal column, and the nickel is the size of the nerve roots that go down through it. There's not much room there. And if those nerve roots are damaged, now we could have all kinds of possibility for paralysis. So you really got to be sensitive to that. If you think that somebody could possibly have a spinal injury, then you've got to really take some special. Somebody falls off a ladder, for an example. That's a trauma situation. Trauma situations really cause a rescuer to really start analyzing and look and see what are the potential injuries here. And it's always better to be safer than sorry. And so even if you have to grab somebody by the head and neck and hold them in position and they don't think it's necessary, do it anyway till the professionals get here, and then they can make a decision. And 9 times out of 10, they're going to throw a neck collar on them, neck brace, and then put them on a spine board. So until they get an x-ray. Once they get an x-ray, then they can get cleared. Okay, any questions on head, neck, and back injuries? Okay, let's move on to heat emergencies. Again, because it's an emergency, it's not just uncomfortable. If this is an emergency, then we need to get the professionals here. Call 911 or have someone do that for you as fast as possible. First thing is get the victim out of the heated area and get them into a cool environment as fast as you can. Move them to a cool place. If they have perspiration-soaked clothing, then you want to remove it. If they have tight clothing, you want to loosen it. You want to apply cool, water-soaked cloths to the skin because you want this evaporation process to take place and start cooling the body down as fast as possible. Yes, sir?
All right, so what is the difference between perspiration-soaked clothing and then applying cool water-soaked cloths? Why isn't the perspiration-soaked clothing an evaporative?
It is, but the best thing is to get that off of there because the clothing itself will hold the heat.
Okay.
So get that off of there and get them cooled down with a different cloth with cool water applied to it. So it's, I don't know if any of you have ever experienced it. I went through heat stroke 4 times. As a firefighter, we're constantly exposed to it. And if you have heat exhaustion or heat stroke, you're more susceptible to it in the future. It's easier to get it again. So you need to really take some immediate action. If you think about what's happening, what you're really doing is you're cooking the brain. Okay, that's what the heat is doing. It's just like having an extra high fever. And we know that we have to get the temperature down as quickly as possible because the brain is what's going to be affected. When you start seeing somebody that, let's say they've been doing some sort of athletic activity and all of a sudden they start acting really kind of strange and they're getting confused, and you got a real issue and it's got to be dealt with now. You can't wait. That's something that's real serious. If it's available to you, you want to take ice or cold packs and you want to apply them in places where the major blood vessels are closest to the skin. So like under your armpits, okay, you have your brachial artery running through there. Up here on the neck are the carotid arteries. So if you get ice packs or something that's cool on these areas, down in the groin muscle, you've got the femoral artery that runs through the groin area. Get something cold on there, either an ice pack or a cold pack of some sort. Get it in those areas so that as that blood is pumping through that's superheated, now you can start to cool it down with these ice packs. You can also apply it to like the wrist and the ankles, again, because you've got a lot of like the radial artery that's running through your wrist. Those areas where the arteries are closer to the skin, you want to get that ice pack applied to it. Fan the victim. Again, that's gonna help with the evaporation, get things cooled down a lot quicker. Place them on their left side. Why do we say left side? First of all, does anybody recognize what this position's called?
Yes.
It's
It's
from,
a recovery.
I heard it,
Recovery position.
the recovery position. If you went through the CPR course, you should have some information about that, the recovery position. We want to turn them on the side. First of all, why do we turn them on the side?
We can breathe better then.
Makes it easier to breathe. What else?
Drainage.
Drainage, okay? Maybe they're not bleeding, they may not be vomiting, but they're certainly producing some saliva. And if we're laying on our back and that's gathering in our mouth and at the back of our throat, we could aspirate. We can suck that down into our lungs. That's a bad thing. So we want to turn them on their side so that all those fluids can drain out and go onto the ground somewhere. Now, why specifically the left side? Does anybody remember that from the CPR class? Why specifically the left side? And it's not that critical, but it's preferable. Anybody know? Okay, let me see if I can explain it to you. Okay, little anatomy and physiology here. Our heart is just left of center in our chest. The two major blood vessels that feed the blood back to the heart are veins, okay? They're called the vena cava. You have the superior, which is higher, and you have the inferior, which is lower. One of the things about veins that's different from arteries is that veins are not under pressure. Arteries are under pressure, veins are not. So the blood that's flowing back to the heart is not under pressure. So now, if we have the patient laying on their right side, all of these organs in our abdomen, everything shifts. Gravity just kind of pulls everything over to the right-hand side. Those organs are now laying on the vena cava that's trying to return the blood to the heart. So it makes it a little more difficult for that blood to get back to the heart. How can we overcome that? Put them on their left side. Now the organs shift to the left, and that frees up everything on the right-hand side, and this vena cava can do its job more efficiently. Does that make more sense? So if you have a choice, and sometimes we don't, but if you have a choice, and you are going to lay them in a recovery position, you're better off doing it on the left side than the right.
The other conflict that I told you that was the recovery position in this particular one.
Yeah.
That we had when we did the AED things.
Yeah.
American Red Cross.
What do they say?
They want them on your right side.
Okay, that's why I don't represent American Red Cross. Here's the other thing. If you have a pregnant female, hopefully it's a female, you have a pregnant female and is carrying a fetus, and you lay them on their right side, now the fetus is putting pressure on the vena cava, right? So that's another reason why we do that. So we just automatically put everybody on the left side if that's available to us. Sometimes because of the situation, we can't. We don't have a choice. But if you can, then put them on the left side, regardless of what American Red Cross says. Okay? All right. Fan the victim and place them on their left side. If conscious, only if they're conscious. All right? Don't try to force liquids into anybody. They've got to be able to drink this on their own. You don't feed it to them. You don't cause them to try to drink it out of the glass that you're pouring. They have to be able to take it and do it for themselves, okay? Because if they are so far out of it that they're not capable of handling that glass on their own, they may aspirate that liquid. So only if they're capable of drinking it on their own. Give them cool water. Not cold, because we don't want to shock anything. We want to do it slowly. So we're going to give them cool water, about a half a glass, about every 15 minutes. okay, to try to get things cooled down. What the paramedics are gonna do when they arrive is they're gonna start throwing a couple of IVs in there, and they're gonna start running normal saline solution, and they're gonna get them cooled down pretty quickly. So, yeah.
I was wondering, like, say if it's your neighbor or somebody in your house, would it be good to have like a Gatorade? Would that?
Oh, absolutely, yeah. That's why I bring this stuff all the time. Okay, this is zero. Because the calories don't help me. But it's all the electrolytes that are in it.
Yeah.
That's why I bring it all the time.
So that would be, would
Yeah,
probably better?
that would be better than the cool water, if it's available to you, okay? Yeah, because you remember, if they're going through a heat emergency, what has happened to all the electrolytes in their system? They've come out with the perspiration. So the quicker we can get that stuff back in there, the better off it's gonna be for the patient. Jerry?
If we only have like 1 or 2 ice packs, is there one area that would be best to put ice pack on?
I would say on the carotids, and here's the reason why. Because remember what we're trying to do, we're trying to stop the brain from cooking,
Yeah.
correct?
Yeah.
So let's get that area cooled down as fast as we can. Right, yeah, I would start, good question. I would start there, okay? If you're limited on how you can cool them down, start up here, because we want to protect the brain. Good question. Any others? All right, let's flip to the next one, which is nosebleeds.
I do have a question.
Shoot.
Should we take ice packs or something with us when we start doing our rounds, or hope that they have ice?
Well, I don't know what your protocols are here. I know in my personal first aid kit, I carry ice packs.
That's what I wanted to know.
They're chemical, of course. You break them.
Break the thing.
Yeah, but I have some of them in my own medical bag. So, I mean, it's good if you got them and you want to, carry them with you. It's better than not having them.
Yeah,
But you can use regular old ice.
right.
Okay.
Frozen vegetable.
Yep, bag of peas,
Yeah.
anything like
That's
that.
my favorite.
That all works good. That all works. Just remember what the rule was. Never put the ice directly on the skin. Have some sort of a barrier, like a washcloth, a little towel, something, but have some sort of a barrier between the cold pack and the skin itself, because you don't want to hurt the skin. Okay, moving on. We good? Nosebleeds. Have the victim sit in a chair leaning forward. What do we do most of the time? Right?
Right.
We have them looking up at the ceiling. Where's all that blood going?
And their throat.
Right down their throat. What's the problem with that?
You can aspirate.
Now they can aspirate again. That's our problem. And so we're better off to let them sit in a chair, because this way they're not falling over. That's one good thing. Have them sit in a chair, lean forward, and let that blood come out. The next thing that we can do is pinch the nostrils together, all right? And hold them for about 10 or 15 minutes. That seems like a long time, especially if you're the patient. That seems like a long time. But what we're trying to do is let that blood clot. We want it to clot up as best that it can. The other thing that we can do to speed the process is we can apply ice packs to the nose and the forehead. And again, bag of peas, whatever. You can put it on the forehead, and you can also put it on the nose, right on the bridge of the nose, okay? So that cold will get things to clot up a little bit quicker too. If the bleeding continues, if you've held for 10 or 15 minutes, and you release pressure and they're just flooding again, and nothing's slowing down, now it's time to call 911. That's pretty serious, okay? And they're gonna get to the ER and they're gonna do some things over there that are not the most pleasant, but they'll get the bleeding stopped. They use something called a rocket, and it's not fun. I'm not even gonna tell you what it does. Okay, any questions on nosebleeds? All right, seizures and convulsions. Pretty serious again. It's not something that we want to mess with, so we want the pros there. So let's call 911 or have someone do it for you. Next thing we want to do is have the victim laying on the floor. Why do we do that?
They can't fall.
So they don't fall down. Very good. Yes, Robert.
I had something happen to me. My son went into a grand mal seizure,
Yep.
and he was, his face was on the table with the, and he had me pinned. And my wife was calling 911.
Yep.
And I looked at his eyes and he just went right back into his head.
Yep. Yep. There's a lot of different causes for seizures. It may not be from epilepsy. I mean, there's a lot of different things that can cause even a heat emergency.
Well, they changed his medicine.
Okay.
Yeah.
But even like a heat emergency can cause, seizures. Medication can cause seizures. There's all kinds of different things that can cause seizures. What you have to think about is what's going on here. It's a disorder in the brain. Okay, there's a problem with the brain. Something's causing that brain to misfire. It could be electrolytes are out of whack. It could be all kinds of different things. But the point is, we need to get the victim onto the floor so that they're not falling down and injuring themselves further. And if possible, we want to put something soft under their head, because many times, if they're going through, as Robert described, grand mal seizures, which is a lot of action, there's a lot of muscle movement, a lot of things going on, convulsions, they're probably going to be hitting things. So get stuff away from the victim. Move chairs out of their way, get tables out of their way, try to protect them as much as possible. In previous times, we used to grab a hold of them and try to hold them in position. Not a good thing for both parties. They get incredibly strong, for one thing, all right?
And they resist it like crazy.
And oh yeah, and they get in, and they don't know what they're doing, okay? They get incredibly strong, and the next thing you know, the rescuer is getting hurt,
Yep.
all right? Plus the fact that if you're forceful enough to hold them in position, just their violent reactions alone could be breaking bones and everything else. So we want to stay away from them. We just want to clear objects away so that as they're thrashing around, if they're actually experiencing a grand mal seizure, if they're going through that, then we want that to dissipate. And it will, okay? It's pretty violent at times, but we want to just let the patient go through their thing, because we're not going to be able to stop it, and just protect them as best we can. The other thing that we have to remember too is that when they come out of a seizure, their brain has just gone through some really, really violent exercise. It's just like we were, running in a race somewhere, and now we're exhausted. And when they come out of that seizure, they're going to be very sleepy for a period of time. It takes time to recover from that. They've just experienced an electrical storm in their brain. That's really what it's all about. And so they get really tired from all of this. And it's going to take time for them to re-engage, to be able to understand what's going on, and to know what's happening around them. And so when the seizure is over with, the convulsions have stopped, now what we want to do is put them in what position? Recovery position for the left side, all right? Again, because they're going to be extremely tired. They may not even be fully awake. All we know at this point is that they stopped shaking. So let's put them in a recovery position. They may have fluids coming out of their mouth. They may have vomited. So we want all that stuff draining out, and we want that patient to be able to breathe easier. And so let's put them on the left side in that recovery position.
I have
Never.
a question.
Yes, ma'am.
Before he flipped it, in the old days, they used to recommend putting something in the mouth.
Yep. We used to carry
And
bite
I think
sticks.
that's-
We used to carry bite sticks.
Yeah.
We used to carry, I don't know if you remember, but we had it was green in color. It was about that long, and it looked like a huge screw. It was threaded, okay? It was plastic. And what we'd do is we inserted it in the patient's mouth.
Between the teeth.
We'd force his teeth apart as much as we could, get the point in there, and then twist that thing to get his mouth opened up, because he's biting down, okay?
The idea was not to bite the tongue or.
Correct. And in the process of doing all that, we injured several patients. You know, we broke teeth.
Yeah.
I mean, inadvertently, but it happened. But that was the protocol at the time. All right, so none of that, we don't do any of that anymore. Those big plastic screws were taken off the ambulances 20 years ago, so we don't do that stuff anymore. But that's how we used to do things, and they found out that there's problems with it. So never place anything in the patient's mouth. What was the reason why we put something in their mouth to begin with?
So they didn't bite the
Bite
tongue.
off their tongue.
And they used to say, well, he's gonna swallow his tongue,
That's right.
right?
Right.
How can you swallow your tongue? It happens to be attached,
Yes.
right?
Well, the idea would it fall back in your throat, but if you're laying, it's not gonna happen.
But that's what they said, is he's gonna swallow his tongue, get a hold of his tongue. And then people were getting bit and so on.
Yep.
Anyway, fortunately, we've changed.
That's good.
Any other questions or comments on seizures or convulsions,
Just
Jessica?
when you turn the patient over on your left side, do you try to bend their legs like a baby, that type of thing, so they don't roll back?
Yeah, there's an actual procedure on how we, in fact, Thursday night, we're gonna go over it, okay? But when you roll a patient into a recovery position, what you wanna do is, and I'm gonna have to put the microphone down.
Pull the leg up over the.
What you wanna do is take their arm that's farthest away from you and bend it across their chest. That's one thing, okay? The arm that's closest to you, you always roll the patient towards you, never away. You always roll them towards you. So the arm that's farthest away from you, you cross their chest. The arm that's closest to you, you put it straight over their head. Now what you do is you grab a hold behind their shoulder and behind their knee. And you pull them in one complete motion all at once. Now as they come over and they're on that side, this arm that was across their chest, now that arm is against the floor. And they can lay their head on it. Their head can lay on their hand. And this arm is against the floor. This knee that you pulled on to turn them over, that is now bent, and that's on the floor, and that's keeping them from rolling completely onto their face. Okay? Does that make sense?
Yes.
Okay. And then what we're gonna do is monitor them. We're just gonna make sure that they're breathing okay, and if not, we're gonna start doing CPR. So we flip them back again and do the CPR. Any others? All right, where were we? Next page, seizures and convulsions, page 13. This is kind of critical. It helps the paramedics a great deal and the docs at the hospital. Observe the victim's type of convulsions. Many times they'll be, as Bob was pointing out, it could be a grand mal seizure where there's violent actions, kicking, thrashing, everything's moving, and they're rolling all over the place. It could be that violent. In other times, they may be just in a trance. My niece is a teacher, and she was teaching pre-K, and she had a little boy in her class that when it came time for recess, he remained seated in his chair. And she thought that's unusual because he's usually the first one out the door. So she went over to find out if everything was okay, and he was just staring off into space. It was like the lights are on, but nobody's home. He had no idea where he was. He wasn't responding to anything. He was just sitting there and just staring. Kind of a dead stare on his face. So it panicked her because he didn't respond to anything that she was saying, and so she called the ambulance. Well, the poor little guy was having a seizure. Okay, it wasn't a grand mal seizure, it was a petit mal seizure. And so that's another form of seizure. Seizures come in a lot of different varieties, and so just because they're not thrashing around doesn't necessarily mean they're not having a seizure. So observe the victim's type of convulsions, and when the paramedics get there, let them know what you observed, because that will help them with the treatment. They will start administering IVs and appropriate medication depending on what in many cases it's Valium. okay, just to calm everything down. We'll give them Valium. And so it's important to let them know what you observed, because they weren't there. You know, they didn't see it, so they don't know what it was all about. You're the one that's going to be able to help them out. The other thing that you can do is, once you observe that there's a seizure taking place, then try to time it. See how long it lasted. And more importantly, if it ended and then started up again, we want to find out how much time elapsed in between the seizures. Because it could be one seizure after another seizure after another seizure, and that again determines on how they treat this patient. And so it's really important to pass that information on to the rescuers so that they know how to appropriately treat. And again, lay the victim on the left side after the convulsions have stopped. So we're going to put him in that recovery position. Anything else on seizures or convulsions? It's all pretty simple stuff, right? You just have to know how to do it. There's no special equipment needed here or anything else. It's just, here's what you can do to help out. All right, let's move on to shock. And this is not electrical shock, as I mentioned earlier. There are 8 different forms of shock. And so the good thing about shock, when someone's going into a medical shock, not an electrical shock, but when they're going into a medical shock, there's a lot of different symptoms that you can recognize if you're paying attention. What you can look for is, does the patient appear to be restless? Are they just like kind of agitated, not quite sure what's going on? Do they have cool, moist skin? I was playing pickleball with a lady here a couple days ago, and as I passed the pickleball to her, I felt her fingers, and they were like ice cold. It's like 85 degrees out, but her fingers are ice cold. And I said, do you feel okay? And she said, well, yeah, I feel just fine. I said, okay. I said, when we get done with this game, make sure you drink something. Because I thought maybe she was dehydrating. But more importantly, that's a symptom of going into a medical shock. And she was experiencing cool, moist skin. You feel the arms, and they feel like they're wet, but they're cool. It's not like it's perspiration, it's different. What's happening in shock is that the blood vessels are starting to shut down on the surface, because it's trying to bring all the blood back to the core area to protect the most important vital organs, the heart, the lungs, the pancreas, etc. So the body sacrifices the blood vessels on the surface and reroutes the blood to the areas that need it the most, the brain, etc. And that's why you start feeling cool. People's skin starts feeling cool, and they break out into it becomes moist. It's not really a perspiration, but they start getting moist. Sometimes they'll experience dizziness. Oftentimes anxiety and confusion. You know, they get really easily agitated for no apparent reason. They may be very weak. And what you're actually witnessing is something called compensated shock. And what happens is that patient, especially with an adult, not so much with a kid, unfortunately, but with an adult patient, you can watch them actually spiraling downward. Okay, you watch, if you're able to take vital signs like blood pressure and pulse and all that side, you'll see the symptoms. You'll see things happening, and they're spiraling downward. And it will get to the point where they will enter a stage which is called decompensated shock and irreversible. So no matter what's done, IV fluids, medication, you can't bring them back. So the critical thing with shock is to recognize the symptoms as early as possible so that the appropriate action can be taken. And so you as a first responder, maybe being the first person on the scene, if you start seeing any of these kinds of symptoms, then your mind should be saying, oh, they're going into shock. And what you can do as a first responder is over on page 15. So if you witness these symptoms and you start taking appropriate action, one of the first things is obviously call 911. You need the guys there with all the equipment and all the drugs. Next, lay the patient on their back. Elevate their legs approximately 12 inches. Why are we elevating their legs? We want the blood flow going back to the core areas, don't we? Okay? Instead of the body having to work to get the blood back, since the veins are not under pressure like arteries are, let's help the body a little bit by elevating the legs and let that blood flow back to the core areas. Next, keep the victim warm. Remember, when you touch their skin, they're cool and they're moist. Well, and there's no blood vessels near the surface are shutting down. So they're gonna get cold. So we now need to cover them up. Even in days like this, you can go into shock. It doesn't have to be cold weather. You can go into shock and you still have to keep them warm. Do not give anything by mouth, including water. And many times the patient will exhibit thirst. They'll ask for something to drink and you have to deny them. You cannot give it to them. And so these are some of the things that we can do. Lay them down, elevate their feet, keep them warm, and then monitor them. Because if they continue to decompensate and go down, 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 you may find yourself doing CPR. So you really got to monitor that patient, yes.
Is there anything that predisposes a person to this kind of shock?
No, because there's 8 different forms. There's septic shock, there's hemorrhagic shock, there's hypovolemic shock, there's 8 different types of shock. So I'll give you an example, like for us down here, all right, in this kind of environment that we're in, we can become dehydrated, hypovolemic. We have, hypo is low, hyper is high. We could have low volume, all right, low volume, so it's hypovolemic. We've used up a lot of the fluids in our body because we just perspired like crazy. We were out playing tennis and sweating like crazy and not rehydrating. We could go into shock. We could go into hypovolemic shock. All right, there's cardiogenic shock, of course we can't determine that, but you know, the heart develops an issue and you develop cardiogenic shock. So there's 8 different kinds of shock. And can you identify the person that's gonna be in shock? No. No, you can't. There's psychogenic shock, which a lot of us can experience, and that is from fright, okay? Psychogenic means that we were frightened. And sometimes, let's say you're walking down a dark hallway and somebody jumps up and goes, "Whoo!" You might fall right out on the floor, depending on your disposition and how frightened you were. That's called psychogenic shock. Well, guess what? That resolves itself because they faint and then they come back. Right? So we don't have to treat that. But if they're out for any period of time, let's elevate their legs, let's keep them warm. That much we can do to help them.
Regardless, their reaction is the same, what you should do.
Yes, no matter which form of, and you don't care what form of shock it is, if you see these symptoms, I'm seeing shock. Let's do something about it. Let's say you're wrong. Let's say you misdiagnosed them and it's not shock at all. Are you going to hurt the patient by laying them down and elevating their feet and keeping them warm? Not really. Okay, and don't give them anything by mouth. Any other questions? Any other thoughts?
I'm just thinking about that lady who you were playing pickleball with,
Yep.
or whatever. Because that'll happen to me sometimes where I'm walking along in summer
Yep.
and my hands get really cold. I think it's just poor circulation, but is it the beginning of that?
No, not really, and it could be brought on by your medication. I mean, there's a ton of things that can cause it. But my paramedic brain says, oh, that could be a sign of shock. So that's the first thing I'm looking for. All right, that's just me because that's how I'm trained. But it could be a lot of different things that can cause it.
Okay,
So.
thank you.
I keep telling my wife that she's going into shock because she puts her feet on my back when we're sleeping. figure it out.
They lay her on the floor and raise her feet tall.
Maybe she's trying to treat herself by elevating her feet. Okay, let's move on to stroke, which is number 16. Here's what we look for. Sudden weakness or numbness of the face, arm, or leg on one side or both sides of the body. Sudden loss or blurring of vision in one or both eyes. Sudden difficulty with speech or understanding the spoken word. Sudden confusion. Sudden severe headache with no apparent cause. Sudden dizziness, unsteadiness, or a fall. Notice the one thing about all these, it's all sudden, okay? It happened like right now. It didn't come on gradually, it happened like right now. Next page. This is what we call our stroke assessment. This is what we can do in the field. It's called FAST. It's just a little mnemonic to help you remember what it is. But the first thing that we're going to do is we're going to look at the patient's face and ask them to smile. See if they can do a perfect smile, or do an appropriate smile, I should say, because sometimes when a person has a stroke, they'll experience facial droop. So you try to have them smile, and one side will go up and the other one doesn't move at all, because that side is paralyzed. So that's the first thing we do, is check their face. Next, we ask them to raise their arms. Okay, and we want them to raise them together, like so. And if they go, we got a problem. They might be able to move it a little bit, they might not be able to move it at all, but that's a problem. Okay, so we're going to check their arms. Speech. Ask the person to repeat a simple phrase, and it could be whatever you want them to say. Listen for words slurring and correct repeating of the phrase. In other words, are they hearing you appropriately, and then are they able to repeat back what you just said? Maybe they can say it okay, maybe they're not slurring, but they've got everything kind of mixed up. That's another indication that there's a problem going on. And so, if we experience anything in those three areas, their face, their arms, or their speech, then we know that we've got to act quickly. Now with strokes, used to be when I was treating patients, we had 2 hours from onset of stroke to get them to the hospital before they could, when they were within the window of administering a clot buster. Now they've extended it as 3 hours. And in certain cases, certain individuals, it could be as long as 4.5 hours, that's all good. But the point is, there is a point in time where the doctors are no longer able to use the clot buster. It's too late. My mother-in-law suffered a stroke at home on her own. She happened to have this about 10 o'clock at night, and my sister-in-law discovered her at 8 o'clock the next morning. It was too late to do anything. And so time is really critical with a stroke victim. And so we need to find out when the onset of the symptoms were. The doctor's going to want to know that. And that's going to make the determination as to whether or not they try to administer something called TPA. It's tissue plasminogen activator. And that's a clot buster. And they cannot administer that after a certain period of time, okay? It is a clot buster, and it can cause bleeding. It in and of itself carries some risk, and you have to sign a waiver and all that kind of stuff to even have it done. But without a clot buster, many times people will have permanent damage. And so if you have, if you know the time when all of this was initiated, make sure that that's known to the rescuers so that they can pass that on to the doctors, because otherwise they have to assume it's too late and they won't even offer it. So it's important to, if you can identify the time when all of this started, let them know. All right? Any questions on that? All right. Yes?
Can I ask,
Yeah, that's over on the next page. Okay, it says stroke treatment on page 18. And it says, if any deficiencies, and there you go, any deficiencies, so if any of those things show up, if any deficiencies are noted, even if they're temporary. What is a temporary stroke? Anybody know? It's a TIA, okay? It's a transient ischemic attack. That's what it's called, a TIA, a transient, meaning it comes and goes, okay? It comes and goes. Ischemic says it's lack of blood flow. So it's a transient ischemic attack. The person that gets a TIA, they'll probably have more than one. In fact, they may have them several times throughout that same 24-hour period. But it's a precursor for a major stroke, okay? It's just an indication, man, it's coming. You know, it might be a couple months from now, but it's probably coming. So they need to take some actions. And unfortunately, what a lot of people do is they experience these symptoms, and it only lasts for a couple of minutes, and then they feel better again, and everything's fine. They're talking okay, their arms work, and they can smile, everything's good. And they don't want to go to the hospital, of course. But if they don't get to the hospital, things are just going to progress to a point where they get worse. If they get some treatment, they may be able to put this thing off for years. You know, if they get blood thinners on a regular basis and that type of thing, they might be able to push off this stroke for a long, long time. And so, time is really, really critical. Yes?
I've heard people say give an aspirin. Is there any truth?
An aspirin is a blood thinner, okay? We do give aspirin for what we suspect to be a heart attack, you know, an MIA, a myocardial infarction. We will give an aspirin. That's a general protocol now, even for lay people, to give an aspirin. For a stroke victim, it's really not going to do anything to help. There's two forms of stroke, all right? There's an ischemic stroke and there's a hemorrhagic stroke. There's two types. Ischemic says the blood flow is not getting to a certain part of the brain, all right? Why is that? Well, the blood vessel's probably blocked. You know, there's a clot in there. That blood vessel has gotten clogged up with something. That's an ischemic stroke. However, you can have what's called a hemorrhagic stroke. What would you guess that one is? Yeah, they're bleeding like crazy, aren't they? So that blood vessel is not blocked up. It broke wide open. And that result is the blood that was needed to get to that portion of the brain is no longer getting there. It's either stuck in the vessel or it's bleeding out throughout the rest of the skull. And it's not reaching the point where it needs to get to. And that's why you exhibit all these symptoms that we just talked about. So, the best thing that we can do is, the aspirin is probably not going to be sufficient to break up that clot. The reason why we use it for cardiac emergencies is because what it does is it thins the blood. It makes the blood easier to pass through the heart. That's why it's effective for a cardiac event, but not for a stroke event. All right? So if you gave it to them, it's not going to hurt them. Okay? It's not going to hurt them at all.
I'm going to cause more bleeding in the brain?
Possibly. I mean, it'll thin the blood somewhat, but it's not going to be enough to really do any harm to them. If they get to the hospital and they're within the time frame, the only thing that's really going to fix it is going to be TPA, you know, the tissue plasminogen activator.
It's kind of useless to give it to them.
I'm sorry?
It's kind of useless to give him or her in a stroke condition aspirin.
Yeah, it's not going to help them. It's really not going to help them. Cardiac emergency, yes. Okay, cardiac's fine. Stroke victim, it's really not going to help them. Okay?
1 or 2 aspirin.
For cardiac, 1, and it's adult. It used to be a baby aspirin at 81 milligrams. Now it's a full strength 325. Okay. And the best thing to do is give them chewables if you've got them, because they'll enter the bloodstream quicker. Okay. chewable aspirins. They'll work faster than if they swallow them and have to go through the gastrointestinal tract.
Yeah.
So if you've got them, you know, that'd be a great thing. Sir?
It sounds to me that you can, if you're by yourself, you can do a stroke assessment. You can look in the mirror.
Sure.
Why not you can do it?
Sure you can.
There are times I say, well, I think I'm having a stroke. I think we all do that, don't we?
Yeah, yeah.
It's my time.
Yeah. Yeah, you can assess yourself. You're absolutely correct. It's a lot easier than giving yourself a shock with a defibrillator. All right. Here's the thing that we can do to help our patient while we're waiting for the rescuers to arrive. Remain calm and reassure the patient. Here's the thing that people don't understand. Most of the time, these stroke victims, they may not be able to communicate with us, or they may be communicating in a way that it's hard for us to understand them. You know, they're slurring, and they may not be able to talk at all. But that doesn't mean that they can't understand everything that's being said. They recognize it, they hear it, they know what's going on in most cases. And so the best thing that we can do is we can try to reassure that patient, get them to stay calm, because the worst thing that we want to do is get them so excited that their heart starts pumping even more, and we're pushing more and more blood to the brain. And the other thing that we don't want to do is we don't want to lay them down. Why would you think? Why don't you want to lay them down?
Pressure to the head.
More pressure, right? What did we do with a stroke patient? With a shock patient? We elevated the legs. Why? Because we wanted to push the blood to the core areas, to the more important parts of the body. So if we have a stroke patient, we don't want all that pressure going to the area that's under pressure. We want to take some pressure off of it. So the best thing that we can do is we can have them sitting, or at least if they are lying down, keep their head higher than the rest of their body. That will take some of the pressure off that brain. Do not raise the feet like we did with a shock patient. So any other questions on strokes? It's one of the things that we may encounter, in our age groups. That's one of the things that we're going to encounter probably more frequently than a lot of other things. So it's quick to identify it, quick to notify the rescuers, and get them to a hospital as fast as we can so that they can take the appropriate steps. Hopefully it'll be in time. Any other questions? All right, let's go on to last page, 19. Unconscious or unresponsive. Is that an emergency?
Yeah.
Oh, yeah. Yeah, so we want 911. What's that?
My wife thinks so. I'm always unresponsive.
Well, she doesn't call 911, huh? All right, so we want to call 911 because we know it's an emergency. We don't know what the problem is. We don't know what's causing it, but if they're unconscious or unresponsive, that's not normal. So we need the ambulance here as fast as possible. If they're unconscious or unresponsive, then we want to check for breathing. Now, we want to find out if it's present, and more importantly, if it's an adult, is it normal breathing? What's normal breathing? You've all been doing it. I've been watching you. I've been paying attention. What's normal breathing? No noise. No noise. Okay? Normal breathing is silent. So if we see chest movement, we know that the chest is moving up and down, and we don't hear anything, guess what? That's normal. If they're normal, if they're breathing normally and they're unconscious, what's our next step? What did we do for the there you go. What did we do for the person that was having the seizures? Put him in a recovery position, didn't we? Okay. So if we have an unconscious or unresponsive person, but they're breathing normally, put them on their left side if possible. Get them in a recovery position so that any fluids are draining out, makes it easier for them to breathe. Okay, if it's a child, we're not gonna listen for normal breathing. We're just trying to find out, are they breathing at all? Okay? Many times it's kind of hard to identify if a child is having a respiratory emergency, so what we're trying to do is, are they breathing at all? And so the best way to do that is get your head right down, or the face right down next to their mouth and their nose. See if you can hear anything. Maybe you can feel it on the side of your cheek. Put your hand on their chest, see if you can feel the chest moving up and down. And if it's an adult and they're not breathing normally, or if it's a child and they're not breathing at all, you have to start CPR. And that's the 2 criteria for starting CPR. They're unresponsive and they're not breathing appropriately. Appropriately for an adult would be normal. Appropriately for a child is not breathing whatsoever. Okay, so we want to start CPR. Place the victim on their left side in a recovery position and monitor their breathing if they are breathing normally. All right. Any questions at this point?
I have
No.
a question.
Yes.
A question about the first drill we had. I was a victim, and I had low blood sugar.
Yeah.
And how do you assess that?
How do you assess low blood sugar without having a glucometer?
Yeah.
Okay.
What do you do if someone's there and they're, I don't know, I talked kind of stupid but not one person got what was wrong with me in the thing. You know, they had to fill out a questionnaire.
Yeah.
And one person figured out.
And what
did we look for?
And what did they do? What was done for you?
Nothing.
Not a thing.
Oh, I think they got orange juice maybe. Or
Okay.
Survived, obviously.
Yeah.
Okay.
It was in a drill though.
Okay.
Thank God.
All right, so there is nothing in there about altered mental status, because that's really what you're talking about, I believe, is altered mental status.
Yes, I was.
There's a lot of different things that will cause altered mental status. One is when the chemicals are out of whack. Well, what's the chemical with somebody that's diabetic?
Sugar.
Sugar, okay? So if their sugar is out of whack, the chemistry is out of whack, so something has to be done to fix that chemistry.
But how could they have known that was wrong? What was wrong?
Without a glucometer, you're only guessing, okay? You're still only guessing. The best thing,
Are there symptoms?
the best thing that you can do is you have to start talking to the patient or someone that's familiar with the patient, a family member or whatever, and ask, because it depends on what their sugar level is. I mean, they could be low and not feel good, but still be able to respond to you. Oh yeah, I'm a diabetic and I took my insulin. Okay, but if they're below that, you know, if they're below that level, because normal sugars should run between 80 and 120, okay? That's typical. If they drop below 80, they're gonna start feeling a little bit confused. They may start getting somewhat anxious, depending on how aware they are of the situation. I think the lowest one I ever picked up was driving a car and ran off the road, and she had a blood sugar of 17.
Oh my God.
And she drove for 30 miles before she ran off the road. But anyway, the point
What
is,
I'm getting at is, in here, we have some older folks.
yep,
And some of them, I was nice. I was nice.
yeah, we do. As a matter of fact, we do. I agree with you.
Some of them, I know myself are
Right.
diabetic.
Yep.
And I wanna know, like I acted like I wasn't really responsive to their questions.
Okay.
But I didn't really know how to act as a
Okay. So,
diabetic.
so now here's my question as a rescuer. If I approach somebody like that, and I have very little medical training, if any at all, if I approach someone like that and they're not acting normally, is that a possible emergency? Yeah, maybe. Would you want to call 911? Okay. between the time that you call 911 and the time they get here, which might be 15 minutes, 20 minutes, guess what? That patient's not gonna die because they have low blood sugar,
Okay,
okay?
you can't die from it, or you can?
Oh, you can, but
But
if
how,
you,
I don't know how low it is.
if you're talking to them and they're responding, but they're not responding appropriately, first of all, we don't know if it's a sugar problem. We don't know if they're a drug addict. We don't know if they've been drinking.
Yeah.
We don't know if they're having a stroke. Like I said, there's like 4 different general areas that are affecting the brain that may or may not be diabetes.
Okay.
All right?
So you would not give them anything?
At this point,
No.
because I don't know anything, you know, if I'm not a trained first responder, if, in fact, even as a paramedic, before I would do anything, if I saw someone that wasn't acting exactly right, guess what the first thing I did was? A blood stick.
Oh.
They got a glucometer test.
Oh, really? Okay.
Immediately, okay, immediately. I was at ground zero. I was taking care of the firefighters that were doing the searching at ground zero.
Oh.
We had a National Guardsman that collapsed in front of us. He was on guard duty, and he collapsed in front of us. He was like 20 years old. So our orders, our protocols were load him in the ambulance, take him to the Army Field Hospital, which was a tent set up at the edge of the property. So we were only like from here to the courts away from him. So we threw him in the ambulance, run him over there, and the Army doctors wanted to treat him. An hour later, they called us back. You'll have to come and take this guy to the local hospital. We don't know what the problem is, but we need you to take him to the hospital. So I got over there and I said, I asked the doctor, I said, what have you done for him so far? Well, we've been running IVs because we figured maybe he was dehydrated. Okay. What else have you done? Well, that's about it. He just hasn't come around. It's been an hour and we've given him a lot of fluid. So I said, have you tested his blood sugar? No, we haven't done that. Guess what? I'm doing it right now. He was only 62 and he collapsed. So I started an IV, I gave him D50, dextrose, and within 20 seconds, he was wide awake. In fact, when we got him to the hospital, he got out of the ambulance on his own and carried his own IV bag in with him. That's how quickly that they'll respond. And so my point is, if it is diabetes, and that might be the cause of why they're acting weird, you can do something, but you're better off not to at this point. Not being a trained person, okay, and I'm talking to the vast majority of the group here, you're better off not doing anything because you might do something that could be harmful. Let's say, for example, that they're really low in their response and they're kind of out of it, they're almost like they're drunk, and you say, here, drink this orange juice, and they're having a hard time drinking it, well, they could aspirate that, okay? So you don't want to do that. So you're better off not doing anything in a case like this and let the professionals figure it out.
Okay, now if this person says, I'm a diabetic, can you get me some orange juice or a piece of candy?
Well, if they're that responsive, that's different.
Okay.
Okay, that's totally different.
Okay.
Yeah.
Okay, so I'm diabetic, and sometimes I get working in the yard, and I'm not really thinking about it, and all I had for breakfast that morning was, well, I drink 12 cups of coffee. So that's about it. There's no food, you know, I've taken my meds because on my routine is 6 a.m. and 6 p.m. I'm taking my meds. So I'm out working in the yard, I'm sweating, I'm working, I'm cutting, I'm stuffing stuff in the trash can. I start feeling really bad. I go inside, my blood is below 60. Just like that. And it was like, you know, my normal first thing in the morning reading is about 125. And so I immediately, I've got those, they're glucose tablets. So I chewed on a glucose tablet, you know, checked my blood a few minutes later, popped a second one. And, but it can come on, that's the whole thing, is it can come on and you're busy doing stuff and you don't even think about it, and you got things to do and places to go, and you skip that meal, and next thing you know, you're in bad shape.
But at
So
least
it
you
happens
had
that
sense
quick.
enough to go in and.
Well, I felt like hell.
We had a,
Brian, do you have an ID bracelet?
Yeah, he does.
But do you check for people if you have some?
well, sure, if
Think
you're,
about that. Check,
that's,
they should have.
when you go through a first responder course or an EMT course or anything else, that's one of the first things we teach. And it's,
to check.
sometimes it's a bracelet, sometimes it's a necklace, but we always look for that stuff. But, you know, you folks aren't trained, and so we're just trying to give you some things that you can do. We had a lady, my wife and I were on a cruise, and we were in the dining area, we had lunch. And I was setting my plate down on the table, and this lady fell face down right in front of me. And so, went over to, and she was out of it. I thought maybe she'd knocked herself unconscious when she hit. So I rolled her over, and she was breathing okay, and she, what happened, what happened? And then her friend that was with her said, oh, she's a diabetic, and we were coming down here for lunch because she's really low on her blood sugar. And I said, okay, hang on a second. And I said to my wife, Sally, I said, get me one of those pieces of cake. And we took the cake frosting and put it under her tongue, because that's where it's absorbed fastest, is under the tongue. It's called sublingual. And it's absorbed into the bloodstream much, much faster. So we just put that cake frosting on it, and she woke right up, just boom. And now, her friend is, come on, let's go back to the cabin. No, 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 you gotta sit down and have a meal. That cake frosting is gonna last you about 28 seconds, and then you're gonna go through this again. So we made her stay there, and she had to eat a meal. And by this time, now the nurse from the, because somebody had called the infirmary, the doctors, and so they sent a nurse up there, so.
But if I go on a cruise, I wanna go with you.
Have Krispy
Well,
Kreme in your medical bag.
I'm sorry?
Have Krispy Kreme in your medical bag.
Yeah, well, you know, honest to truth, one of the things, in fact, I've got in my medical bag, and on the ambulance, they used to have this stuff, it was glucose paste in a tube, and you would squeeze it out and get it under the patient's tongue. It tastes awful. Tastes really awful. So guess what we switched it with? Cake icing. In a tube, okay? They like the taste a lot better. In fact, now they want to take the whole thing. And yes?
Another thing to think of is a lot of seniors forget to take their medicines.
Yep.
And if they're off their meds or they're having trouble affording the medication and they're having it and things like that, that can cause a big problem, and you don't want to get.
That's what I'm accused of all the time. I'm off my meds.
Well, I've been told that too.
Any other questions or comments or thoughts? All right, let's take a quick break. Let's if we can, let's get back in about 5 minutes, and then we're going to look at these scenarios real quick.